Now let's move on to protraction and arrest in the active phase. So remember, protraction means delay, arrest means complete halt. So what are some risk factors for active phase protraction and arrest? Number one, like always, is hypocontractile uterine activity. Remember we talked about how the uterus contracting is a trigger for cervical dilation and effacement. So if you have poor uterine activity, how are you going to dilate and efface the cervix? You're not. So key indicators: if you have weak, infrequent, or short duration contractions. Good contractions are strong, frequent, and have a pretty prolonged duration. And this will allow for cervical dilation and effacement and progression of the active phase. So how do you diagnose this? There are two ways to do this. So the ways you do it is external tocodynamometry, which means you have an external monitor that tracks the pressure and the contractions of the uterus. And you also have an intrauterine pressure catheter. And what this does, you put a catheter inside of the uterus and measure the pressure of the contractions. And you want the contractions to be at least 200 Montevideo units. If it's less than 200, you're having weak, inadequate contractions. Another reason to have protraction and arrest is cephalopelvic disproportion. So the head of the baby and the pelvis of the mom are disproportionate, not allowing for delivery. So the head can be too big or the pelvis can be too small, preventing the baby from being delivered. So how do you diagnose this? Physical exam. So physical exam can tell you if the head of the baby or the vaginal canal of the mom or the area between the ischial spines is big enough to allow the baby to pass through. You don't actually need an ultrasound here. So a protracted active phase, what does this mean? The definition is you have greater than 6 centimeters cervical dilation and dilation of less than 1 centimeter an hour. So greater than or equal to 6 centimeters dilation, because that means you're in the active phase, and dilation of less than a centimeter an hour. So if it's dilating less than a centimeter an hour, you're in protracted active phase. And how are you going to manage it? Like you manage everything here, oxytocin. So even if contractions are adequate, you can give oxytocin, because what causes these cervix to dilate and efface? Oxytocin and contractions of the uterus. What triggers uterine contractions? Oxytocin. You can also give an amniotomy if the membranes haven't ruptured yet. An amniotomy can help by triggering the uterus to contract more, and you can also give oxytocin afterward. So an arrest, what is an arrest defined as? That means you have more than 4 hours of no cervical dilation. So there's no cervical dilation for 4 hours. That's a sign of arrest, and that's with adequate contractions, and you need to do a C-section in that situation. And if you have more than 6 hours of no cervical dilation with inadequate contractions, in this situation you also need to do the same thing. Okay? So if you're having very slow cervical dilation, you're going to give oxytocin regardless if the contractions are adequate or not. But if you have more than 4 hours of no cervical dilation, even with oxytocin and contractions, a C-section is needed. And if you have more than 6 hours of nothing with inadequate contractions, even including oxytocin, you do a C-section also. Remember, this is the second part of the first stage, the active phase of labor, being delayed and arrested. Now let's talk about the second stage. Remember, we talked about how the second stage of labor is from the active phase finishing to the expulsion of the baby. So what are some risk factors for this? Epidural anesthesia. Why would epidural anesthesia be a risk factor for the second stage of labor being prolonged or arrested? Because the mom is getting anesthesia of the epidural space and is losing feeling in her lower pelvic area, and she has to push. How's she going to push if she can't feel anything? That's why epidural anesthesia can be it can be beneficial for pain and other things, but actually worse for the second stage of labor. And nulliparity, if they've never done it before, this is a new experience, and it'll be much more difficult for them to handle. So what's the definition? 3 hours of pushing with no fetal descent in a nulliparous woman. This is the definition of arrest. 3 hours of pushing with no fetal descent at all. So arrest means no movement, 3 hours in a nulliparous woman, and 2 hours of pushing in a multiparous woman. Alright, these are all things you have to know, and they will test you on this in OBGYN parts of the shelf exams and the Step 2 CK. If you have epidural anesthesia, you need an extra hour of pushing before you can diagnose with arrest. When do you give oxytocin? You give oxytocin after around 60 to 90 minutes of pushing if the following criteria are met. If there's no descent, or even absent descent for 60 to 90 minutes, you need to give oxytocin. And if uterine contractions are happening too far apart. If they're more than 3 minutes apart, that's not good, and oxytocin can help bring these contractions closer together. So if there's an arrest, as in these criteria being met, an operative delivery is needed. So you can do C-section, forceps, or vacuum. And there are different indications for each. So you do a forceps or vacuum if you can still do vaginal delivery, and it's safe. If there's any cephalopelvic disproportion or some kind of major contraindication to vaginal delivery, a C-section is needed. So only if all of the scenarios are not possible, do a cesarean delivery. Now let's talk about intrapartum fetal heart rate abnormalities. So you can have a lot of issues with the fetal heart rate during the delivery process. So the purpose of the fetal heart rate is to tell you how well the fetus is being oxygenated and how the well-being is. So if you have a normal heart rate, you've got good oxygenation and good well-being, but high or low heart rates can indicate major problems with these two factors. So you have to monitor the fetal heart rate during labor. This is mandatory. And a baseline fetal heart rate will be between 110 and 160 beats per minute. This is a lot different than me and you. We have around 60 to 100 being normal. Babies have 110 to 160. They have a much faster baseline heart rate. So what are some causes of tachycardia? Anemia because of less blood, so the heart needs to pump more blood to get more oxygen to tissues. Infection due to sepsis and vasodilation causing a reflex tachycardia. Fever because of increased metabolic rate. And poor fetal oxygenation because the cardiac output is going to increase to account for this poor fetal oxygenation to allow for more blood to circulate in the fetus. What are some causes of bradycardia? You can have bradycardia from poor fetal oxygenation because the heart's not getting enough oxygen to pump properly, hypothermia because lower temperatures decrease the metabolic rate, and hypoglycemia as well because the heart needs energy to pump, and without energy and oxygen it cannot pump well. What about variability? I'm sure you've heard this term a lot, variability. What does that really mean? Variability means that the heart rate goes up and down. It's not just staying flatline the whole time. It's not just staying at 110 or 120 only. It goes up around 10 here and there, now and then. And moderate variability, meaning like having 10 to 15 beats per minute different, is a good sign of CNS oxygenation. You're getting good CNS oxygenation, meaning that you have less hypoxia and acidosis. So variability is actually a good thing. If you don't see variability, you should actually be concerned. See this? Minimal or absent variability, consider pathology. But just because there's minimal or absent variability does not mean there's hypoxia or acidosis. There are other indicators of these that we will talk about. So what are some fetal heart rate accelerations? So heart rate accelerations mean that you have fetal heart rate increase of at least 15 beats per minute for 15 seconds. And these accelerations are signs of fetal movement and good predictors of well-being. That means that the baby is getting good oxygenation, having good fetal blood flow, and good fetal movements. And this is a good sign for the fetus.